Hello everyone, this is Eric from Stanford University, and today I'll be presenting an introduction to hypertension. The specific learning objectives of this video are to define systolic and diastolic blood pressure, as well as hypertension, to list the different ways in which hypertension can be classified, to list the common risk factors and etiologies, and last, to describe the general mechanisms responsible for its development. You'll notice that this video is not covering treatment. Routine treatment of hypertension will be the topic of a forthcoming video, and treatment of hypertensive emergencies is already covered in another video with the links over there. Let me start the talk by first asking, what exactly is blood pressure? Blood pressure is the force per unit area exerted by circulating blood on the walls of the arteries. As a consequence of the cardiac cycle, blood pressure is cyclical. The maximum pressure in the arteries occurs in the middle of systole, which is the part of the cardiac cycle during which the heart is actively contracting. This is naturally called the systolic blood pressure. The minimum pressure in the arteries, which occurs at the end of diastole when the heart is relaxing, that's called the diastolic blood pressure. When someone reports a blood pressure as 120/80 or 160/110, what's being reported is that the systolic blood pressure is 120 or 160 and the diastolic pressure is 80 or 110. So the top number is systolic, the bottom number is diastolic. To help understand this a little better, here's a graph of blood pressure as a function of time. As time passes, the pressure quickly rises and then gradually falls over and over. The top number here is the systolic blood pressure. The bottom is diastolic blood pressure. Hypertension, put simply, is high blood pressure. Usually, this means that both the systolic and diastolic are too high. Occasionally, particularly in the elderly or in patients with significant psychomotor hyperactivity, such as hyperthyroidism or psychosis, one can get isolated systolic hypertension. And rarely, particularly in patients with poorly functioning hearts, patients can be observed with isolated diastolic hypertension. But usually, the two blood pressures go hand in hand and rise and fall in equal proportion. So why is hypertension important? Well, to start with, approximately 25% of the world's adults suffer from it, and at least in the US, only 50% of those with hypertension have their blood pressure under adequate control. Hypertension is a major risk factor for all kinds of problems, most notably coronary artery disease, also known as heart disease, both ischemic and hemorrhagic stroke, heart failure, kidney failure, retinal disease and blindness, and peripheral vascular disease. And appropriate treatment of hypertension clearly helps to mitigate the risks of all of those life-threatening complications. So why aren't patients with hypertension better controlled? Well, there are two major factors. First is lack of access to medical care. As people both in the US and outside of the US know, Obamacare notwithstanding, there are still many people out there who don't have primary care doctors, and for a variety of reasons, they are unable to receive routine health maintenance visits. The second factor is non-adherence. Although antihypertensive treatment is relatively effective, it can be difficult to convince patients to make major lifestyle changes or to take on one or more medications for decades when the condition that's being treated is almost always asymptomatic while the patient remains in the early stage when a difference in outcome is otherwise easiest to achieve. Related to that, there are no obvious immediate benefit of treatment, at least treatment with medications, but there are obvious immediate medication side effects. I've already defined hypertension as simply an elevation of a patient's blood pressure, but can we be more specific than that? Hypertension is specifically defined as a systolic blood pressure at or greater than 140 and or a diastolic blood pressure at or greater than 90, averaged over two readings as measured at each of two or more separate clinic visits. In addition, hypertension should not be first diagnosed in the setting of acute illness for example in the hospital, unless it is unusually severe or there is end organ damage consistent with chronically poorly controlled hypertension. I'm not going to cover the actual mechanics of measuring a patient's blood pressure at this time, but the link to the left reviews it pretty well. I'll now move on to the classification of hypertension. There are several different complementary approaches to how it can be classified. The first is the easiest, as it's only based on blood pressure measurement. If the systolic pressure is under 120 and diastolic pressure is under 80, the patient's pressure is considered to be normal. If the systolic pressure is 120 to 139 or diastolic is 80 to 89, the patient is considered to have prehypertension. This is a borderline category, which can be used in clinic to successfully convince patients to embark on lifestyle changes, such as weight loss, in order to reduce the chance they slide into the frank hypertension category. That hypertension category is divided into stage 1 and stage 2. In stage 1, either the systolic blood pressure must be between 140 and 159, or the diastolic pressure must be between 90 and 99. In stage 2, the systolic pressure must be 160 or greater, or the diastolic pressure must be 100 or greater. If the patient's systolic and diastolic values fall into two different categories, the patient is considered to have the more severe category of the two. For example, if the patient had a blood pressure of 170 over 95, it would be considered to be stage 2. Although this classification system is easy to use since it's completely objective, the major disadvantage is that it implies there is one optimal range of blood pressure for all patients, which is not true. There are some patients, because of other medical problems such as heart failure, in whom a blood pressure of 120 over 80 might be suboptimally high and still require treatment. This is as good a spot as any to point out that the prognostic importance of systolic and diastolic blood pressure is age dependent. In patients over the age of 50, the systolic blood pressure is a more important predictor of cardiovascular mortality, whereas in patients under 50, the diastolic blood pressure is more important. A second way to classify hypertension is based on etiology. The overwhelming majority of patients with hypertension, about 95%, have what's referred to as primary hypertension, or alternatively, essential hypertension. This means the elevated blood pressure is not caused by another pathophysiologic process in a clear direct cause and effect relationship. 5% of patients have secondary hypertension, in which the blood pressure elevation is directly caused by another disease. Another way to look at it, for patients with secondary hypertension, if the primary disease is treated and cured, the hypertension will necessarily resolve. There are several additional important classification terms with which you should be familiar, all of which are considered forms of hypertensive crisis. The combination of severe hypertension, variably defined but most commonly considered to be a systolic pressure above 180 or a diastolic pressure above 110, plus no symptoms or acute end organ dysfunction, is given the term hypertensive urgency. What would be an example of acute end organ dysfunction? Pulmonary edema, chest pain, confusion or retinal hemorrhages, not better explained by another condition. In contrast, severe hypertension plus either symptoms and or acute end organ dysfunction is considered to be a hypertensive emergency. There is one last term that crops up from time to time, and that is malignant hypertension. Most commonly, both laypeople and suboptimally informed medical professionals use it interchangeably with hypertensive emergency. However, in the medical literature, it is specific for the combination of severe hypertension and either retinal hemorrhages and or papilla edema, which is an ophthalmological finding of increased intracranial pressure. Therefore, as you might conclude, malignant hypertension is a specific subtype of hypertensive emergency. For anyone interested in learning more about hypertensive crises, including their treatment, you might want to check out my video on acute hypertension with a link available at the top. The only thing more I'll say about the hypertensive crises is that hypertensive urgency is not life-threatening and can usually be treated as an outpatient, while all forms of hypertensive emergency are life-threatening and hospital admission is always indicated. When it comes to risk factors for primary hypertension, there are many. The modifiable risk factors are generally the more important. They include obesity, smoking, sedentary lifestyle, excessive dietary sodium intake, and excessive alcohol intake. In addition, there is limited evidence suggesting that low dietary potassium intake may also be a minor risk factor. Non-modifiable risk factors include age, with the highest risk of new onset occurring in the 50s and 60s, also family history, particularly a parent, and finally, being of black race is a risk factor for both having primary hypertension, and blacks with hypertension have a higher risk of significant complications such as stroke. Among all of the risk factors mentioned, the single most important appears to be obesity. Whenever I mention this to a patient or even in casual conversation, it's not uncommon for someone to reply something like, "Hey, but I know this guy who's overweight and his pressure is just fine." That's because that person doesn't understand what a risk factor really is. So consider this graph of the relative frequency of finding a particular systolic blood pressure in American adults with a particular BMI or body mass index. We'll split up the pressure into normotensive, prehypertensive, and hypertensive categories. For patients with normal BMI, that is a normal weight given their height, the frequency of blood pressures empirically follows a normal distribution quite nicely. That is, it forms a classic bell-shaped curve. About half of adult Americans with a normal BMI have either prehypertension or hypertension. Then look at the distribution of adults who are obese. It's still a nice bell-shaped curve, but shifted upwards a good 20 millimeters of mercury. Thus, there are still obese adults who are normotensive, but just not very many, relatively speaking. I'll now talk about the pathogenesis of primary hypertension. In other words, what causes primary hypertension? The mechanisms involved are numerous, complicated, and incompletely understood. Entire textbooks about this have been written, but I'll keep the discussion focused on only the most fundamental principles of the best established processes. Looking at the big picture, primary hypertension is a result of dysfunctional communication between 5 organ systems: the heart, the brain and spinal cord, the endocrine system, particularly the adrenal glands, the blood vessels, and most importantly, the kidneys. Superimposed on all of these various connections are a multitude of genetic effects, diet, particularly salt intake, and physical activity. To understand the basic mechanisms behind hypertension, I need to review just one equation, which is largely considered to be the most important equation in all of bedside medicine. The mean arterial pressure is approximately equal to the cardiac output times the systemic vascular resistance. Broken down into more layman's terms, this means that the average blood pressure is about equal to the rate of blood flow from the heart times the narrowness of the blood vessels. And cardiac output is largely dependent upon 3 factors: heart rate, that is, how fast is the heart pumping; myocardial contractility, or how strongly is the heart pumping; and diastolic blood volume, or how much blood is in the heart when it pumps. Therefore, elevated blood pressure must necessarily be due to one or more of the following: increased heart rate, increased myocardial contractility, increased blood volume, and increased arterial constriction. If a patient is hypertensive, at least one of those 4 physiologic derangements must also be present. As far as medical science understands regulation of blood pressure, there are 2 major physiologic systems responsible for hypertension. They are the Renin-Angiotensin-Aldosterone System, often abbreviated RAAS, and the sympathetic nervous system, which is one of 2 subdivisions of the autonomic nervous system, or that is the part of the nervous system that controls our body without us needing to think about it. There are almost certainly other contributing systems and components. They include endothelial dysfunction, for example, dysregulation of a compound called endothelin-1, impairment of nitric oxide synthesis, and oxidative stress. Also included is cytokine dysregulation. There are several others as well, but these latter contributors are not well understood at this time and play little to no role in the development of a treatment strategy for hypertension, so I'll talk more only about the top two. What's the Renin-Angiotensin-Aldosterone system composed of? It starts in the liver, where the prohormone or inactive hormone precursor, angiotensinogen, is produced and released into the systemic circulation. In the kidneys, an enzyme called renin is produced, stimulated by low renal perfusion pressure or low blood pressure as felt by the kidneys. Renin converts angiotensinogen into another prohormone, angiotensin-1. The lungs produce another enzyme called angiotensin-converting enzyme, which takes angiotensin-1 and transforms it into the active hormone angiotensin-2. Angiotensin-2 has three major effects related to blood pressure. First, it leads to systemic vasoconstriction of the arteries. Second, it leads to increased renal sodium reabsorption in the kidneys. This sodium reabsorption results in increased water reabsorption, which then expands blood volume. The third effect of angiotensin-2 is in the adrenal glands, where it stimulates the conversion of steroid precursors into a steroid hormone called aldosterone. Aldosterone has a number of actions, both direct and indirect, but its main action related to blood pressure is it also stimulates renal sodium reabsorption. So the net effect of increased activity of the renin-angiotensin-aldosterone system is vasoconstriction and sodium reabsorption, the latter of which leads to increased blood volume. What about the sympathetic nervous system? The sympathetic nervous system is very complicated, and a complete discussion of it is well outside the scope of this video. Just focusing on blood pressure, however, the first component is a reduction in systemic blood pressure noted by peripheral baroreceptors in the carotid arteries and aortic arch. These baroreceptors send signals via cranial nerves 9 and 10 to the brainstem, where the sympathetic portion of the autonomic nervous system translates that message, sends a new signal down the spinal cord and out to the tissues. Some of the signal travels through peripheral nerves, where they locally release norepinephrine. Norepi release at the heart binds to beta-1 adrenergic receptors, where it causes heart rate and myocardial contractility to both increase. Norepi release on blood vessels binds to alpha-1 adrenergic receptors to induce systemic vasoconstriction of arteries. Finally, sympathetic signals delivered to the adrenal glands results in the systemic release of epinephrine and, to a lesser extent, norepinephrine. These compounds travel in the bloodstream, where they reinforce the actions caused by the locally released norepi. Moving on to secondary hypertension, there are many etiologies, most of which also require the renin-angiotensin-aldosterone or sympathetic nervous systems. The most common etiology of secondary hypertension is something called renovascular hypertension, in which focal narrowing of one or both renal arteries results in low renal perfusion pressure and an inappropriate increase in renin activity, which increases the overall activity of the renin-angiotensin-aldosterone system. Other relatively common causes of secondary hypertension include chronic kidney disease, hyperaldosteronism, a pregnancy complication called preeclampsia, and numerous medications, of which NSAIDs, oral contraceptives, and steroids are the most notable. Less common etiologies include obstructive sleep apnea, Cushing's syndrome, pheochromocytoma, hyperthyroidism, hyperparathyroidism, and coarctation of the aorta. And when I say here that these are less common etiologies, that does not mean that obstructive sleep apnea is less common than preeclampsia or less common than hyperaldosteronism. It means that OSA or sleep apnea is less commonly a cause of secondary hypertension than those other conditions. My last topic in this video will be to review which subset of patients with hypertension should be screened for causes of secondary hypertension. There are some red flags that suggest secondary hypertension in general. These include resistant hypertension, defined as inadequate control despite seemingly adequate doses of 3 or more antihypertensives, any form of hypertensive emergency, age of onset before 30 in the absence of major risk factors, or age of onset before puberty, irrespective of risk factors. If you see any one of these 4 in a patient, they should be screened for secondary hypertension. Then there are some red flags that suggest a specific diagnosis. For example, aspects of a patient's presentation which specifically suggest renovascular hypertension include the onset of unusually severe hypertension after age 55, sudden deterioration of renal function shortly after initiation of a medication in the ACE inhibitor class, asymmetric kidney sizes on ultrasound or abdominal CT, and an abdominal bruit on exam lateralizing to one side of the abdomen instead of being midline or bilateral. Other specific red flags include paroxysms of hypertension associated with headache and/or palpitations, which suggests pheochromocytoma, severely discordant blood pressures between upper and lower extremities, suggests aortic coarctation, which is extremely rare in the adult population, and finally, unexplained electrolyte abnormalities. Hypokalemia and/or hypernatremia is typical of hyperaldosteronism, and hypercalcemia can suggest hyperparathyroidism. That concludes this introduction to hypertension. If you enjoyed this and found it helpful, you may also want to view my accompanying video on the management of hypertension.